Hello, my name is Ali and I'm one of the GP trainees working in SHAC, and thank you for listening to this presentation on syphilis and chlamydia co-infection in MSM and antimicrobial antagonism. This slide shows different types of antimicrobial action. Penicillins work by preventing the formation of intact cell walls. It is important to note that the bacteria need to be actively dividing and replicating for penicillin to have an effect. These agents are therefore known as bactericidal. Tetracyclines, however, work by inhibiting protein synthesis and prevent replication, so these drugs are called bacteriostatic. Simultaneous use of bactericidal and bacteriostatic antimicrobials can result in antagonism and prevent the action of these antimicrobials, particularly their bactericidal agent. There's both in vivo and in vitro evidence of this mechanism, as you can see in this slide. Here are the historical studies of antimicrobial antagonism between penicillins and tetracyclines. In 1951, a US study of 57 patients with pneumococcal meningitis showed that patients treated with both the tetracycline and penicillin had a higher mortality than those treated with penicillin alone. Similarly, in 1955, a Swedish study of 315 patients with scarlet fever showed that patients treated with both penicillin and tetracycline had higher relapse rates than penicillin alone. And finally, in 1961, in the United States again, in 35 patients with pneumococcal meningitis, it was shown that patients treated with both penicillin and tetracycline had higher mortality than patients treated with penicillin or erythromycin alone. These studies are small and not controlled, but suggest that caution needs to be exercised when using bactericidal and bacteriostatic agents simultaneously. The in vivo data is not so clear, as some studies have suggested antagonism in isolates of E. coli, but other studies have not shown antagonistic effects. The top two graphs in this slide show the epidemiology of chlamydia and syphilis in all men in the past decade. As you can see, the chlamydia graph is flat, and the syphilis graph shows significant increase in the population group. The lower graph shows syphilis, the dotted yellow line, and chlamydia, the dark red line, in MSM, showing significant increases in both in MSM cohort. Indeed, we can see from this chart that MSM are affected disproportionately by bacterial STIs. It's estimated that MSM make up between 2 to 3% of the population, but account for 23% of cases of chlamydia and 90% of cases of syphilis. The issue is that in MSM who are diagnosed simultaneously with early syphilis and chlamydia, the treatment is potentially antagonistic, and this slide shows the first-line treatment we use for both of these conditions. Here is a case report of a 44-year-old MSM presenting with a rash and urethritis in 2006. His VDRL was 1 to 32, and he was simultaneously treated with 3 weeks of benzathine and 7 days of doxycycline. His simple symptoms resolved in a week. However, by the second week, he started to develop blurred vision, and by the third week, he had signs of optic neuritis. Here you can see the retinal images showing a blurred optic disc in picture A and mottling of the retinal epithelium in picture B. The black arrow in picture B also shows foveal hemorrhages. In this patient we're discussing, his colour vision was impaired. Continuing this story, the patient's MRI brain was reported as normal, and a lumbar puncture showed a lymphocytic picture with a positive TPPA. He was admitted and treated for neurosyphilis with 2 weeks of IV benzoyl penicillin. His eye signs were resolving by day 10 and had resolved by 12 months, apart from some defect in his colour vision. The authors of this case suggest that its initial resolution of symptoms, followed by neurological syphilis, may have been due to antagonism between penicillin and doxycycline. There are no comments on simultaneous use of benzathine penicillin and doxycycline in any of the international guidelines, including BASH and CDC. However, both the summary product characteristics of doxycycline and benzathine advise avoiding their simultaneous use, as you can see from this slide above. What we did was we aimed to determine the prevalence of chlamydia in MSM with early syphilis, to explore the features of MSM with syphilis chlamydia co-infection, and to determine the treatment and treatment outcomes of MSM with syphilis chlamydia co-infection. We used our existing database of syphilis cases in MSM in 2019 and identified MSM who were diagnosed with syphilis and chlamydia on the same episode. We then reviewed the clinical notes of the patients with co-infection and collected data on their management and treatment and microbiological outcomes. The results are shown here. There were 155 MSM diagnosed with early syphilis in 2019. There were 21, or 14%, diagnosed with chlamydia on the same episode. The median age of MSM with dual infection was 43. 17 had rectal chlamydia and 4 had urinary chlamydia. There were none with pharyngeal chlamydia. 3 out of 17 with rectal chlamydia was symptomatic, and 1 out of 4 of the patients with urinary chlamydia were symptomatic. 8 MSM were treated simultaneously with benzathine and doxycycline. 13 were not treated simultaneously with a median delay of 7 days. On further review of this, 3 were found to be treated separately due to clinical concern about antagonism, and 10 were treated separately due to a delay in microbiology results. There were no clinical failures reported, and 15 returned for serological follow-up, and all had at least a 4-fold fall in VDRL titer. MSM with syphilis chlamydia co-infections was significantly more likely to be HIV positive than MSM with syphilis alone only. Otherwise, there were no differences in MSM with mono or dual infection, as this slide shows. In summary, there are no guidance on simultaneous treatment of chlamydia and syphilis co-infection with benzathine and doxycycline, although the summary care products are clear that we should avoid simultaneous treatment. There is only one case report in the literature of an HIV-negative MSM developing symptoms and signs of neurosyphilis after simultaneous treatment. What we found was that 14% of MSM with early syphilis were simultaneously diagnosed with chlamydia, and these were more likely to be HIV positive. Our management, unfortunately, was not consistent. 8 received simultaneous treatment, but there were thankfully no treatment failures. What this shows is that antimicrobial antagonism is complex and poorly understood. There are likely to be multiple factors, including bacterial factors such as bacterial load and turnover, host factors including immune response and pharmacodynamics, and pharmacokinetics. It's interesting that there's only one case in the literature of treatment failure in MSM with syphilis. What we recommend from this is the avoidance of simultaneous treatment given the plausibility and the guidance with a 10-day gap given the known slope reproductive rate of syphilis. In MSM with chlamydia syphilis co-infection, the syphilis should be treated first unless they are very symptomatic from the chlamydia. An MSM with neurological disease should not receive simultaneous treatment with a tetracycline and penicillin. Thank you for listening, and we'll be happy to take any further questions. Thank you.